then to be that navigator and to be involved in surrounding the patient with resources so that they are connected then to that next column, specific to your community, specific to your facility, specific to that patient. What do they need? And that's the laundry list of folks that can be involved and should be involved in their outpatient care, leading to what we call the loop closure, which is the comprehensive postpartum visit. We know that when we look at the data, that a patient actually completing all of those steps was the rarity in our state, which was leading to significant adverse outcomes specific around maternal mental health and sequelae of that, but many other outcomes measurements. We believe strongly that if everybody adopts this new workflow, that in fact we will improve maternal outcomes, family outcomes, infant outcomes, and we will get rid of the black eye that Kansas has in terms of maternal morbidity and mortality in our state. I would challenge all of you that don't look at this or see this to remember this slide. It'll be sent out to you later, and post this on your unit as the standard new postpartum model. We're excited about it. You've been working hard on it. This is what we're focused in for one more year. Next slide. For trimester champions, this is a little nudge to you all. You got an email from me requesting our standard data collection pieces. I really need your birth numbers for 2023. I sent you an email that had specifics on total births, live births, stillbirths, and then the breakdown if it's available to you or if you can pull it off of your data. That includes the breakdown of race for us. For those of you that are using QHI, thank you. You're already putting this data in, but I'm asking you to send it to me as an end of the year data collection piece too. Okay. If you have questions about that, please reach out to me. I'm also gently nudging you to make sure that in QHI, you're putting in data specific about your ED triage. We're going to focus in on that today. And when you embed that protocol, also things like your community resource list. When's the date that you finalized that and started that process improvement piece at your hospital? It likely happened months or years ago. Just make sure that that's updated in QHI if it's not already. In terms of your total birth numbers for 2023, again, to our champions, please submit that data to me by January 30th. Again, if you have questions, reach out to me and I'm happy to help. If you have specific questions about QHI, also ask. For our news sites, I know that feels like a huge lift. We are happy to help you, and our QHI partners are ready and willing to jump in on a separate call as needed. Next slide. So I'm providing resolutions. That's not how that's supposed to go, right? You're supposed to create your own. But Carrie, Jill, and I set out last week with a very intensive strategic planning session to say, okay, how do we finish this bundle, knowing that it will be ongoing, knowing that you all will continue to have support from our staff for years to come regarding postpartum discharge planning and that postpartum model. But what do you need from us? This is your resolution. I need you to take that's coming to you, use it, finish this bundle, and this is how we're encouraging you to do so. We need you to attend each learning forum. We have set out with each month, we'll talk specifically about how to finish an item within the bundle and within FTI. We will follow that up very soon this month with a FTI completion PowerPoint. What are all the projects within FTI? How do I know I've completed them? And what do I need to do to complete the ones that are the pieces that are not completed? We broke it down to make it as easy as possible. Want to make sure that you have TA support from us. And again, we will send that out, walk that through, and make sure that that's clear to you all. Reach out with questions. Meet with us. Carrie and I are happy to meet with you all. That started already. I'll tell you about some specific open office hours we'll have as well, but we're here to help. And then use each other. I have a lot of sites that connect to each other, and I love that opportunity. We'll have some in-person opportunities for that in 2024 as well. But that's part of the wonderful collaboration that happens with FTI is to use each other as sites and ideas. Next slide, please. Contacts. Again, providing this only as a slide, you'll get this as a follow-up, but there are a lot of pieces of, and we know that about for trimester, but look at the experts that are listed here and use them for questions you have as we complete the projects within fourth trimester this year. Next slide. Office hours. Carrie and I are making ourselves as available as possible to each individual site, but wanted to host some open office hours where we get on Zoom for about an hour. These are the 2 sessions that we have set up. So champions and anybody from your hospital that you want to invite to ask questions of us, to walk us through some troubles that you're having or difficulty completing items within the 4th trimester, and to brainstorm with other sites. January 30th and February 2nd. The 30th is at noon and the 2nd is at 8 a.m. You will receive a Zoom link. I think Tiffany's going to send that out with a calendar invite soon after this learning forum. We'll jump on and be happy to help. We will have more of those throughout the year, but those are the first 2. So mark your calendars, pop on if you need to, and we're excited to see you all for those. Next slide. All sites, and actually for all of Kansas, those of you that are involved in any way in the 4th trimester initiative need to know the phenomenal work you're doing. And I think the picture that Carrie has created along with our data experts at KFMC finally have figured out a way to explain to hospitals or show off to hospitals your great work. So we pulled out an example of what this looks like. You may remember the idea of the sunflower, and that when you complete all the petals in the sunflower, that means that your 4th trimester initiative is in fact complete. A 5 means that that project piece is completed. So on this example, the postpartum care team, that means that you have that embedded in your hospital. That's a 5 and a yellow petal. And our goal would be that all the petals around your hospital's sunflower, so to speak, are yellow. And again, you will each receive this report card updated for your hospital. Show it to your administration, show it to your staff, show off what you guys have done. And we will work then with each of you to make all of those 5. Next slide. Now, when we talk about drilling down to what's coming up to help you complete pieces of the 4th trimester initiative, I want to bring to your attention Hannah Figshord. She is, in fact, in charge of the intimate partner violence piece of our project. Very, very important work happening across the state. This Thursday, January 25th from 1 to 3 o'clock, open and free to all 4th trimester initiative participants, in fact, across the state. The link is there to how to register for that event. If you have any specific questions, reach out to myself or to Hannah. You see her email listed there. Again, we really encourage all of our sites to send at least, or to have it in attendance, the virtual training, at least one person to learn about intimate partner violence and how in the world we're going to help that problem in Kansas. Next slide. The next 2 slides are specific about birth equity. We know that birth equity is the cornerstone, the baseline to the work that we're doing in Kansas. And again, we know that from the data coming from Kansas telling us that we have a big problem with birth equity across the state. When I've talked to some sites across the state about convincing their staff that this is part of the very important relearning that we're doing across the state, I've had some questions and some pushback, and while I understand that they don't understand why we have to learn this, I take great care of my patients. I do a phenomenal job hearing and listening. I would challenge everybody to say that may not be true. Again, when we look and we hear the data coming from Kansas, we know that women and families are not being listened to. Medicine is extremely hard to access. There's a lot of automated responses instead of person-to-person contact happening across the state. And women and children and families are having increasing difficulty with feeling like they're being listened to in times of need. So if for no other reason than to relearn how we're providing excellent listening skills to our patients, please reiterate with all of your staff members the importance of birth equity. And so Kansas Birth Equity as a state expert is again who we're using to send out training opportunities across the state. I've connected now to actually we have connected to 3 sites that have completed training. Stormont Topeka was the leader. They did a phenomenal job, figured out how to make it all work with March of Dimes work and with birth equity. And they've completed training at their facility. Hutchinson and Amberwell Hiawatha now have completed KBIN training, doing a phenomenal job at their facilities. And rollout just started for Newman, Wesley, and Lawrence Memorial. Excited to get them going on this content. For the rest of you, we are ready to go. So we will reach out to you, make sure that you know how to register. We are doing a train the trainer opportunity. We can't train all staff members at your location with registrations, but we know we have a great idea for how to get the content to you all. and we'll connect to how to do that. You will then receive an email from KBIN outlining how to access it, and it's phenomenal, phenomenal content. Next slide. We know that we also need to expand on what we have available from Kansas Birth Equity and also hit the mark for one of the bundle items called patient debriefs. This is the piece that says that patients need to be involved in hard conversation, right? When there's an adverse outcome, how do we discuss that with patients and their families? How do we involve them as the cornerstone of that conversation and change to a positive outcome? So we've involved our Mama's Voices. You guys remember them? They presented to us on the patient voice and adverse outcomes. Great group at the national level. And they're agreeing to 3 sessions that talk about birth equity from the patient perspective, and how do you have a hard conversation with the patient when an adverse outcome has occurred. These are going to be really great sessions as well, free to all for Trimester staff. How this will go is the champion will receive these links that you see on those 3 days. We're asking the champions then to send it out to your staff members and asking that all staff choose one of those 3 sessions to attend. You will not be sad. We're expecting, again, phenomenal results and a great relearn of how we're taking care of patients in 2024. Again, further information will come through the champions. Next slide. And breastfeeding. Receive this information. Many of you already have gotten it. Regional hospital skills fairs. Breastfeeding rates have taken a little bit of a, I'll call it a dip only because resources struggled post-COVID. Now, Brenda Bandy and Kara Gerhardt are working it hard to make sure that our hospitals have adequate resources and support to train new staff so we can get those numbers back up and rolling. These 4 spots that you see listed on the left-hand side are in-person training, and further information is available there. You see that the QR code's available, certainly to register. You can also just connect to that link. All of these resources will come out to everyone at the end of the learning forum, but wanted to make sure we brought that to your attention as a really important piece, again, of Kansas's work. Next slide. CMS also, we've talked about this through the last 2 years. It has started, and what I'm finding is that hospitals are not identifying themselves as birthing friendly hospitals, even though all of you that are enrolled in the 4th Trimester initiative are officially birthing friendly hospitals. So I typed in several of you into that link that you see at the bottom left, and used, our own hospital as a look-see, and sure enough, all of you are listed. I don't know that your hospitals know to show that off. That is a very important piece to be proud of, but also to show that you're involved in QI to increase patient safety. And so make sure that your hospital is listed there. If it's not, reach out to CMS, reach out to your QI person and make sure that you're listed, or reach out to me and I can help you. Next slide. Also in the news, I like to grab tidbits, and this came across, actually my stepmother reached out to me and said, have you seen this article? And I thought, man, what a convincing way to then lead into our conversation today about the ED triage of OB patients. But in Neodesha, Kansas, I don't even know how to pronounce that. How embarrassing. But in a small town in Kansas, southeast Kansas, the hospital welcomed a first baby that they had in over 20 years. And how did that baby arrive? Very fast and through the emergency department. And so wonderful article there celebrating the oh my goodness moment that we all know happens occasionally with a precipitous delivery, and the phenomenal care that family received. So again, I like to show off fun stories, but again, an aha moment for why we all need to be involved in 4th trimester work. Next slide. All right, we're going to take pause before we get to our guest speakers. Jill, you're on.
Wonderful. Well, good afternoon, everyone, and happy 2024. It is so nice to see you all. As you should have received in your email, we sent an updated version of our bylaws at the end of December, and then again yesterday. Just as a reminder, we would be voting on them today. In case you are confused, you all are considered part of the KPQC general membership, and so all of you are eligible to vote. Before we launch, I will just say that the most notable changes of the bylaws that were made by the used to be executive committee, now we're moving towards an advisory board. is that name change, and then also just some logistical information around the chair for our advisory board, moving their term from 1 year to 2. We don't feel like 1 year is a sufficient amount for a chair to really get a good grasp of everything that happens within the KPQC. And so those are the most notable changes. Those bylaws were sent out to all of you. And so Tiffany's going to launch the poll here really quickly. All of you are eligible to vote. Please do so. And thank you for your time today on that. Tara, I'll turn it back over to you.
Fastest voting in Kansas ever. All right, guys, let's move into our guest speakers. I want to give them enough time, and we had a lot of content before. Here's the real deal. Part of our attack of this last year for trimester focuses in on, I would say, the outlier pieces. We know how important post-birth is. We know how important standardized screening and referral is, and that postpartum workflow we described. But this piece about the emergency department has always been a little elusive to everybody that's enrolled. Why is it important? What are we doing? We know that the ED and the OB have a interesting history of a love-hate relationship. We'll just say what it is. Yet we know how vital our ED team and colleagues are. And so in this bundle, the AIM bundle, postpartum transitions, which is a gentle reminder again, is the 4th trimester initiative in Kansas. The specific outcome measurement says, has your ED established or continued standardized verbal screening for current pregnancy and pregnancy in the past year as part of its triage process? And it's asking each of our hospitals, our enrolled hospitals and birth centers, to report the start date of when that occurred. Okay. Doesn't have to be 5 years or 10 years ago, but could be in the last 2 or 3 years that you need to report, even if it's been going on before that. So in other words, if you've been doing that, you just need to put a date in. If you haven't started doing that, I want you to listen in today, and it's time to get that piece completed. Next slide. Now, why are we doing this as a secondary piece of that? I need to remind you all that this is not an unrelated benchmark that has nothing to do with Kansas. In fact, the Kansas Vital Statistics just came out in the last few weeks with the 2022 data, which made it even more clear about why the ED is a vital, integral part of us improving maternal outcomes. We see cases in the Maternal Mortality Review Committee over and over again that the ED is a primary access point for our obstetric patients in the pregnancy piece of their journey, as well as the postpartum. We also know that our emergency departments, as part of that sequelae, are missing key postpartum findings because she is not currently or obviously pregnant, especially in the mental health and hypertensive genres of that episode, or that pregnancy postpartum episode. We know that morbidity and mortality then escalates in those missed postpartum moments. Furthermore, we know follow-up from the ED is not standardized protocol, and that if there's an urgent yellow or red flag post-birth related, that oftentimes there's no follow-up or referral completed out of the emergency department, so she's lost to follow-up. As a gentle reminder to all of us, your emergency department is not just taking care of your postpartum patients from your birth facility. They're taking care of everyone across the state who lands in their emergency department. Our facility is right off I-70. I don't need to tell you how many times a patient, pregnant or postpartum, shows up in our emergency department that we don't know anything about. You can't just pull her record, right? And so if the triage question is not part of that triage process in your emergency department, we would have lost that opportunity to help accurately assess and help that patient in that emergency department moment. Pregnancy-associated deaths are clearly connected to, again, red flags found on triage in the emergency department. And I again remind you that once we thought seatbelts and seatbelt use was part of the story we needed to tell about postpartum morbidity and mortality in Kansas, and then we found out it's way more than seatbelts. Perhaps the seatbelt use wasn't the story. Perhaps it was mental health and substance abuse disorder that created the moment, a motor vehicle accident and sequelae. So again, we have to drill down, and over again, we find out that the emergency department is a critical access piece. And so focused in on that today. Next slide. This is just a gentle reminder too about OB deserts. And guys, look where Kansas is. We sit in the middle of a very, very hot, unfortunately hot spot throughout the nation, but certainly within Kansas. I don't need to preach that to this choir. You know that OB units are closing throughout our state. And so the emergency department for many of our patients and our state residents is the only place to get obstetric care in their area. Next slide. Next slide. So here's what we're going to do. We're going to grab some experts. We're going to walk through some case studies. We may go a little long today, so if you can stay on after 1 o'clock, we're going to let these guys share their great knowledge and how to embed and improve upon this important outcome. Next slide. And so these are the three champion and experts that we grabbed. Abby, Jenna, and Kim, we grabbed from across the state because of their current and ongoing work in these departments. Abby's our ED expert, and she'll introduce herself and explain how the heck we invited her again, thankfully, to present today. And then we'll continue with Jenna and Kim, talking about the relationship building between the two departments. If it's been adversarial in the past, how to throw that out the window and make it a positive, and certainly how in the world to embed with case studies. Next slide. And Abby, I'll turn it over to you.
Okay. Good afternoon. Thank you for having me again. My name's Abby Weatherly. I'm a board certified emergency and family nurse practitioner, and I currently function as the clinical nurse specialist in the emergency department and the two outlying facilities for ED that we also have here at Advent Health in the greater Kansas City area. And I'm very excited to share the knowledge I've gained in collaborating with our amazing labor and delivery and obstetrics department at Advent Health Shawnee Mission. We truly have two amazing teams that work together to promote the best care for the specialized and vulnerable population. And I feel like that, honestly, that bond between OB and ED has really increased specifically at our facility over the past few months, because we not only have our emergency department at our facility, but we also implemented earlier this summer a obstetrics emergency department, or an OB-ED. So even getting that up and off the ground and running, I was able to provide some information on regular and non-obstetrical complaints and build processes over there to make the transitions from our emergency department over to the OB-ED, and then also the OB-ED back to the regular ED go a little bit smoother. So next slide. So we have many primary goals, but the big two ones that we obviously know about are patient safety and decreasing maternal mortality rates. Patient safety is always in the forefront of our minds, but Kansas has had one of the largest, the country's largest increase in mortality for American Indian mothers, and a rise from more than 200% from 1999 to 2009 to then 2010 to 2019. So it saw the biggest rise in maternal mortality for Asian, Native Hawaiian, and other Pacific Islanders. So the problem is real. We have very vulnerable populations within the African American community and also the Native American community, where we really need to take a good look at that specialized population. And of course, that's a whole nother presentation for KPQC on another day. But that's the reason behind why we're doing this as well. Next slide. ED triage objectives. So the first thing we need to do when we were working in the emergency department is immediately recognize the postpartum state. Once you recognize that the female is within a postpartum state, we perform a quick triage, timely treat for the symptoms that they're having and the disease and pathophysiology that they're experiencing, recognize the need for the specialized consultation, and then figure out exactly what the appropriate transfer, discharge, or admission is, depending on where your emergency department is located within the state. Next slide. So at my facility currently, we do have a triage algorithm that we use if the mother, I think I went through this on the other KPQC as well, but I just quick reminder that if the patient is less than 20 weeks, the patient will remain in the ED and we do consult L&D as needed. And then if the patient is greater than 20 weeks and has an OB-related chief complaint, and of course is stable, then we contact L&D for transfer. If the patient is greater than 23 weeks and does not have an OB-related chief complaint, we do have the capability to have fetal monitoring in our emergency department that does transmit directly over to the L&D for that specialized visualization and consultation in that manner until we can rule out any life-threatening things. And so if the triage algorithm that we currently use here also on the right side has some ESI triage level tips and tricks to kind of make sure that you get that ESI triage level.
Abby, I think you froze on us. I tell you what, let's keep rolling. Why don't we go ahead and see if Abby can reset? If you slide ahead for me, Tiffany. Keep going. Yep. Nope, there she is. Found her. She's back. Abby, you're muted.
Okay, sorry, I don't know what happened there. So I apologize. Let me grab my. Okay, can you go back one slide again? I'm sorry. Okay, so this one is our postpartum triage algorithm here. As you can see in the box, it does say 12 weeks still. I know that we're supposed to be asking for 1 year. Unfortunately, in Epic, our triage questions have to be approved corporate-wide as we are part of a bigger health system. We have to get through all the launch waves of the Epic for our entire health system and then come together on what's best for our patients. So our algorithm says 12 weeks, but we do talk to nurses in the triage area to question patient presentation for up to 1 year, delivering within the past year. As we all know, we just have so many disease processes that get missed when we don't account for that first year, including some psychosocial problems as well. Next slide. Okay, so I wanted to go through a case study with you all. And here we have a 36-year-old female who is 1 week postpartum. Her chief complaint is that she's swollen all over and her blood pressure is 146/84. That was checked at home. And she also has concerns that her blood pressure cuff was not working correctly at home. She denies any headache, chest pain, or dyspnea. Next slide. And so this one went very smoothly. She was triaged in the ED. Her blood pressure was 158/92. And we immediately called the triage RN called OB for an immediate consult. The patient was transferred over to OB. Labetalol was administered. She was admitted to the hospital and then had a 5-day encounter and was discharged home. Next slide. But we all live in the real world and we know that it's not always that easy. There's a lot of chaos in the emergency department and in the world today. So I wanted to give you just a few other things that you can gather to be prepared for when these patients come to your ED. Next slide. Okay, so this here, you want to know your patients. And so ask questions and review previous visits and history if you can to see what their baseline blood pressure is and what type of class, what class of hypertension that they might be in. These are the ACOG types of hypertension list, and it helps to provide providers in developing plan of cares for patients. Next slide. Okay, and also it helps to have all of the previously developed resources and review those. So ACEP, or American College of Emergency Physicians, does pretty much defer to ACOG, who are the specialists in this population of patients. And so it helps to have checklists, algorithms, and take what's already out there. You don't always necessarily have to develop your own. But this here is a hypertensive emergency checklist, and it helps to guide you through assigning your team, what medications you can use, what's first line, and then anticonvulsant medications as well if needed. Next slide. So have your resources readily available. In our department, we have a triage binder, and it's kind of separated out by different types of disease processes. OB is very high at the priority list because, of course, with this type of patient, we want to immediately treat them, but we also want to get them over to our OB, which is not too far away, our department over there. But having resources ready available definitely helps to initiate proper treatment quickly. And these are always based on, like I said, ACOG guidelines. It can help you determine which diagnostic tests are needed in the first line medications and the timing for patients as well, specifically if they are less than 7 weeks postpartum. Next slide. Always follow the current guidelines. Here's another just ACOG little handout that you could have at the bedside ready to go, or in a place where it can be quickly obtained. This shows you your first line therapies and gives you your doses, and then also your timing of the doses and how often you can repeat these medications. Next slide. Here's an example of just a labetalol algorithm. You could probably make one of these, or there are other ones actually out there, algorithms for all the medications that are first line treatment. But having this quickly as a what to do each step of the way through the process until you can get that patient either admitted if you have an OB department or a labor and delivery department, or transferred out to an outlying facility is very helpful. It's just easy to follow. And sometimes, I'm actually from rural Kansas, so northwestern Kansas, which, as you noted on the map earlier, is very lacking in obstetrics care facilities out there. So sometimes it's just as simple as having all the correct things in the right place that are easily obtainable to help guide providers through that. And, you know, physicians and also APPs, nurse practitioners, PAs, you know, a lot of times out there in those areas, they don't have a physician right on site. So the APPs are taking care of those patients until that, you know, 30 minutes or 60 minutes until the physician can get there, or until transfer can be made. So having these quick references really helps. Next slide. Here's a quick education for healthcare providers, patients, and families. We have these on magnets. Our labor and delivery team got them to us in the emergency department. And so they're actually on magnets that we can hand to the patients, and then they can put those on their refrigerator and just take a quick look and see if they're having symptoms, when they might want to return back to the ED, or when they might want to call 911. So having these quick glance things just really help a lot for patients and families as well. Next slide. And I'll be back in a few minutes.
Abby, you're doing great. I know that IT moment is not fun. Appreciate you jumping back on. Jenna McLean is on with us, doing impressive work in Sabetha, small town with phenomenal outcomes. And so Jenna, I'll ask you to introduce yourself and then tell us how your process improvement is going in Sabetha.
So I'm Jenna McLean, and thank you so much for asking me to present. That's not something I've done very much of, especially when I'm recorded. So here we go. Our situation here, we are a small hospital. And so sometimes it's tough for me to think about what of my work stands out. We do it all, and with limited resources. Many times when I listen to larger hospitals talk about their situations and how they manage those situations, it doesn't seem to be scalable and fit to a smaller facility like us. So therefore, I hope that this helps those that are having a hard time moving forward with the screening in the ER. Next slide. So I am the director of nursing and also our emergency operations coordinator. My staff covers the med-surg department, the ER, labor and delivery and postpartum, and outpatient infusions. We are a licensed 25-bed critical access hospital. Typically, our average med-surg patient census is about 6. That's observation, acute, and swing bed patients. So we do anything from birth till death in our department. We have 2 labor and delivery rooms. So we deliver them, and then quite many times we know them when they come back into the ER. But even as Tara mentioned, living along I-70, we have 2 other birthing centers within 15 miles. So they could live in our town and deliver there, or live in their town and deliver here. And so you never know what's going to happen, especially with weather like we've had recently. So with that situation, we can't have the love-hate relationship with our ED staff and our OB staff, because they're the same staff. We have Cerner for our EHR, and so this is what our FirstNet is the ER side of things. This is what our FirstNet triage questions consisted of until I started working on this project. There's a very strict process in place for making changes within our EHR. Sometimes it can take 2 to 3 weeks to get a change, or it could take up to 7 or 8 weeks. Some items are approved within our domain because it meets Cerner's road mapping, but then sometimes it has to go through a change control process. With this extent of the questions pertaining to pregnancy within our system, we had to go through the entire process. We went live with Cerner back in January of 2017. So, you know, we've had many years to think about this and get it rolling, and here we are, just now getting it done. Next slide. So this is the proposed change that I've made, and it's currently been presented to all the hospitals, and it's gone out for vote. So as soon as we know those results, it will either die, hopefully not, or have to start over, or I will go into the production environment and we can use it live from that moment. We, of course, like all other ERs, are bound by EMTALA rules, where we treat everyone the same, but that really doesn't come into place when you're talking about a childbearing age woman. You know, we really need to kind of pick them out, and so without being able to pick out that population, you're kind of SOL. And I'll get into that a little bit with the case here in a little bit. So this extra question could make all the difference in the world, and it's very simple. We just have the question of pregnancy within the past year, yes or no, and then what are their post-birth warning signs? And then the nurses are supposed to then notify the provider of what those warning signs are, and that they've been pregnant within the last year. Can definitely guide treatment to getting you to the resources that Abby talked about. Next slide. So I've already trained my staff on this, even though the proposed change hasn't gone into place, but I can imagine that would be a huge gap, because you can find that big gap in my labor and delivery and postpartum nurses know what the post-birth warning signs are, but does the ER staff know that those post-birth warning signs, those emergency conditions like chest pain and seizures, are potentially related to their pregnancy? And so we do have a couple staff members that don't do a whole lot of labor and delivery and postpartum, but they do a lot of ER. So we had to go through a little bit more training education with the post-birth warning signs with that staff. Next slide. So this is a resource that we put up. We've all seen this on the KPQC side with the post-birth warning signs, but in the ER, we did not have anything posted that if you've had a pregnancy within last year, you could have any of these signs, and these are things we're going to look at. And so we have electronic boards. All ERs used to have great big posters for ACLS and TNCC and any of the needed emergency conditions. We created an electronic board with a touchscreen computer to pull up all of those different posters. And so we've added this as another slide on that board. So our staff can just quickly click on that they had a pregnancy within the last year, and then bring it up, and then they can go through all of the different possible symptoms they have, rather than just that they're presenting with chest pain. So, of course, I was asked to present a case review to give to you guys, and in a small hospital with small birth numbers and small ER numbers, it's a little bit difficult to come up with, but we did have a situation here locally that I wanted to go ahead and present to you. And if this board would have been in the ER when the patient presented, or if these things were presented to the patient before she was discharged, it could have changed the course of things a lot. If she was educated on these prior to discharge, I don't think she would have struggled to present when she wouldn't have waited so many days, and her treatment plan could have changed a lot. So the patient I am going to talk about was discharged, and within 5 days after delivery, was having headaches, nausea, lightheadedness, fatigue, edema. When you look at those, many OBs don't know what to think when they get home. If they're a first-time mom, they are unsure what changes to expect, and they don't know what is normal unless they're told. But then if we look at these post-birth warning signs, her headache that does not get better, even after taking medicine, or headache with vision changes, is a major one, where she needs to be contacting her provider. So then this patient started having chest pain and started to hear her crackles in her own lungs, so very audible crackles. And then she did present to the ER for care after that, ended up getting transferred to a larger hospital, and had many, many, many liters of fluid removed between MAG and blood pressure medication. She did get discharged home, but if these things would have been taught on discharge, she could have had sought care maybe sooner, and definitely changed the course of her recovery. Last slide. Thanks again for letting me present, and I think we're going to have questions at the end.
Jenna, I think all of us hear you, and first of all, appreciate that you have equal valid input as a small critical access hospital. So I see Abby shaking her head. Thank you for taking the dive today to talk about the unique needs, and I'm proud of the work you've done. All of us are. Next slide, please. And so our last presenter is Kim Dick. I'll let her introduce herself and talk about a great case study that she has too.
Thanks again for having me. A little background. I am currently the quality program manager of our perinatal services here at Stormont Vail. I started here in nursing school and actually worked in both the emergency room and the OB units. So when I graduated, I had that tough decision of which unit to really dedicate my career to, and realizing that OB usually has a little bit of both. That's what I chose. So this is kind of a fun topic for me. Abby, I am so jealous of your OB/ED. That is like one of the biggest goals I think I have. That is just absolutely amazing. But in my role here, I have been part of what we have is called a mother baby response team. And it started several years ago. We meet quarterly, the OB leadership, the NICU leadership, and our emergency room leadership. And we do case reviews, we break down processes, and we just look for any opportunities for improvement. So throughout the years, this has definitely kind of shifted focus multiple different times. And just recently with our involvement in the KPQC, we were able to kind of shift our focus towards identification of either pregnant or immediately postpartum patients. One of the things we decided to do is kind of like Jenna mentioned, our priority became maximizing the EMR capabilities. So that way we are able to identify these patients quickly and easily. That way we are able to get them escorted to the appropriate area with the appropriate staff and providers to treat them best fit the needs of what they're needing. So this first slide here, where the arrow is pointing to, is an example of our pregnancy identification. So anytime we have that stork little icon up there, that just identifies our patients as being pregnant. If you hover to discover more information, it will display further detail regarding the pregnancy, such as like OB care, gestational age, due date, OB history, like G's and P's, as well as any upcoming appointments. So again, just to help drive care. Next slide, please. In addition to our EMR expansion, we were able, oh, I don't know if you have my most current version. That's okay. We have this little stroller icon, and that is to identify anybody who is postpartum. So the second picture down below, if you hover to discover, it will show you the time frame in which they delivered as well. So next slide for me, please. Okay, go back one more then. I apologize that I don't have a picture to be able to show you, but we have another icon that has the stroller with a little eye on it. And when you hover to discover that, it indicates that the pregnancy ended in like a loss. So that way our staff members, our providers are able to easily identify these people who have suffered either a miscarriage, a stillbirth, or something to kind of prompt them to maybe gear their conversation just a little bit differently with that information. So that's really helpful. These identification icons stay on our Epic chart for 365 days following the delivery. So that way we're able to reach that 1 year mark. These icons show up for our clinic visits, our triage phone calls. Anyone who is able to get into the Epic chart will be able to see those icons, so that way if the patient maybe doesn't say, hey, I just delivered last week, or oh, I'm newly pregnant, that the staff who are triaging them will be able to guide their care a little bit better. And again, just a reminder to ensure that the appropriate resources and things are being utilized. Okay, now the next slide, please. I apologize. In the instance that we have a staff member overlook any of these identification features that we've been working in Epic, or if, like some of you guys have mentioned, somebody comes to our hospital that didn't deliver at our hospital, our ER triage staff are really good about screening and asking for pregnancy. But for someone in the waiting room who might be either waiting in line a little bit, or for someone who maybe didn't understand a question, or maybe it wasn't asked in a way that they understood it, we have these signs hanging that just directs them that either if they're pregnant or have been pregnant in the last 6 weeks and are having any of these serious complications, to go ahead and come to the front of the line, just kind of for that quick, immediate response time. I will try to post in the chat the link to these. They're actually from the CMQCC website. That's who we use a lot of our information for with hemorrhage and things like that. So that's where we stole them. But our mother baby response team, like I say, we got together and we've just trying to be able to catch every avenue possible to ensure that we're identifying these patients and that we're also helping them communicate with us. Maybe some of the symptoms they might be experiencing, or if they had one of those symptoms and they didn't realize it was a big deal, if they see that sign like, oh yeah, I did have that yesterday, I should maybe speak up about that too. So just to kind of give the patient a little bit more information and kind of the steering wheel on driving that piece to their care, so that way they know that it's important to let us know everything that they're feeling. And next slide, please. For our OB case study, we had a mama, she was a G3, P2, 35 weeks. She came via AMR, complaining of chest pain and abdominal cramping. She got to the emergency room about 3:50 and she was hypertensive when she first got here. Because we knew she was coming, we actually were able to coordinate some of that care ahead of time. So anytime an ambulance is calling and has a pregnant patient, we page out our mother baby response team, where we're able to get the providers and the charge nurses and the staff members from each of our teams to collectively meet down in the emergency room, and we can kind of make a plan there as to where the best care would be. So in this decision, the birthplace charge nurse was at the bedside upon arrival. She was able to actually coordinate with the OB that was on call to go ahead and start the preeclampsia eval while the patient was being evaluated in the emergency room for their chest pain. So we took a fetal monitor down there and we were able to watch the baby the entire time the mom was getting her cardiac workup. So she got EKG, chest x-ray, troponins, all that type of stuff. Once that was deemed stable, we were able to transfer her to the birthplace for further evaluation based on our needs. Little background, she had no significant medical history prior to this. She had an uncomplicated pregnancy. At 33 weeks, she was diagnosed with hypertension, gestational hypertension. Her preeclampsia labs were normal and she had no symptoms. At 34 weeks, it progressed to mild preeclampsia because she had her elevated protein creatinine ratio, but she still had no symptoms. And then again, she presented at 35 weeks and was really sick. So we did an MFM consult. We got her betamethasone, but she actually ended up having an induction of labor due to severe IUGR, oligohydramnios, and all of those complications. So you can see how if this woman wouldn't have known or wouldn't have possibly been triaged quickly and promptly, there could have been a gap in her care. So next slide, please. Some of the successes, as well as barriers and opportunities that we decided upon when our group met about this. Our successes were, of course, the early identification of the pregnant status. AMR was who prompted that. Their leadership and our leadership have a good relationship. So that was something they implemented months ago, again, at the suggestion of our KPQC meetings. We had good collaboration and early collaboration with our ED and OB teams. The OB was at bedside upon arrival. The ED was really able to own the cardiac workup, and the OB team was really able to focus on like the preeclampsia workup and doing the physical assessment of that as well as the fetal assessment. And the other nice piece to it is once we did decide where the patient would actually be admitted and she was admitted to the OB service, it was nice because our team was already familiar with the plan of care because we had been involved since she got here. So that was really helpful. Barriers and opportunities. I'm sure we all struggle with this a little bit, but as provider to provider communication, it was a lot of our nursing teams collaborating and discussing what the doctors were wanting us to do. So I would say our biggest opportunity was maybe to get the OB and the ED providers speaking a little bit more than just having our staff do it. But overall, I think it went really well.
Hey, Kim, that slide was in your deck. Tara Stroda forgot it.
Oh my gosh.
So, I
No
apologize. After I asked you to add
It
it,
just threw me off for a split second, so we're good.
that OBED part of you just came straight out. So Tiffany's gonna add it in. But anyway, it is an important icon. Using EHR is vitally important. You're totally right. So to complete this portion of our presentation today, we're going to jump back in with Abby. Abby, if you want to hop on and complete the morning for us.
Okay, thank you. And I thank you, Jenna and Kim, for also presenting on yours. I learned so much just from you guys as well. And being somebody from rural America, Jenna, thank you for being the leadership for the rural areas because it's much more difficult out there where you don't have resources. So the second case study I just wanted to present was also a humbling moment for our team in the city who has all the resources. We had a 31-year-old female patient. She was G2, P2, 13 weeks postpartum, and she presented to one of our outlying freestanding emergency departments in the city. She had shortness of breath, a racing heart as a chief complaint, and her physical symptoms were dyspnea, tachycardia, and she also had some psychosocial symptoms of I just can't sleep and I'm feeling anxious. You can tell by her exam that her vital signs were a little bit tachycardic and then slightly hypertensive as well. But at that point, she was discharged home from the ED after medical clearance and sent home and told to maybe have her husband watch the baby for a little bit while she tried to get some rest. So I just wanted to show how, even though we have all the resources in the city, sometimes we don't always get it right. She went home and her symptoms increased and worsened. She started to have not full-on psychosis presentation, but feeling like maybe she was distancing herself from her baby because she didn't want to harm her baby. And so she called our postpartum emotional support advocate, Trisha Rausch, here at Abbott Health. And she encouraged her to go back to the main ED for further evaluation, where we do have behavioral health consults there as well, and a few more resources. And so the patient reevaluated, medical clearance was completed, and she obtained a specialized behavioral health team consultation and was admitted to the hospital for inpatient therapy and treatment, and then discharged home with outpatient resources, medications, and follow-up care. So I just want to point out that even though we have all the resources, we don't always get it right. We make mistakes too, and it's always a constant evolving learning process for us as well. Next slide. Sorry, I think I forgot to say next slide last time. One more slide. Okay, next slide. Okay, so I do want to quote my very good friend and peer, Carrie Smith. You all probably know who she is. She just said, listen to the patient, trust your intuition, and be the best advocate for her that you can be. And so I think that's the best advice that we can give in this 4th trimester. We can build processes, and we can try to get the baby buggy icon. Kim, you guys have yours there for 365 days, and that is an enhancement that we have asked for. But until all of our health system goes live with Epic, we can't get that on our board for 365 days. So it's a lot of education, but I think at the end of the day, you just have to listen to the patient and just advocate for her the best that you can, like Carrie said. Next slide. And so in closing, I just want to say, how do we get there? It's preparation. Provide regular education, reach out to other facilities and disciplines who have processes already built, see what they're doing. I would love to meet with Kim and Jenna offline and just talk to them about some of the awesome ideas they had as well, because we don't have it all together here either. But also just know your available inpatient and outpatient resources in advance. We have for reevaluation, we have a multidisciplinary team for data and process review. We do debriefing, we do chart reviews, risk master type reviews, and we come together once a month to reevaluate things that went well and then things that didn't. And then we develop our process improvement plans from those meetings, implement changes based on the guidelines, and keep learning. It is an ongoing, evolving process. And then for the collaboration, just always strive for excellence, celebrate wins and progress, and join professional organizations where you can get the most up-to-date relevant data and information, and be a voice for Kansas. Next slide. I just want to say thank you again for this opportunity, and there is my contact information if anybody feels they need to reach out to me, and then I will turn it back over to Tara for questions and closings.
So Abby, Kim, Jenna, thank you. I think we could present for 8 hours probably on this topic, and actually it's a extremely requested help, right? So those of us in Kansas that are trying to do more for patients are finding that this is a moment that we know that we can increase access and decrease the gap. So thank you for giving great ideas, and appreciate that you shared your contact. We all will, and I'll share that out too. Tiffany will make sure everybody has each other's contacts. I put this slide one more time here because I think this is a solid version of an algorithm that could be a separate embedded option for your protocol. This will be shared on the slide deck for sure, and so use it if it's helpful. Give credit where it's due. That's why I kept that Advent Health Shiny Mission logo on there. I think it's important to know where it came from. If you have questions about that, you can reach out to Abby for sure, and to Carrie. Next slide. And then a quick save the date for our champions. I've thrown a lot of dates out at you guys. I just put a note to myself that we probably need to make that more synchronous, and one email to get all those dates in for the next few months so that you know what's coming. But our next in-person for the champions, which we are requiring, is April 23rd, with more information to come. That'll be in Topeka once again. Next slide. And we'll let you guys get out of here. Only 3 minutes late because our speakers killed it. You guys, thank you for joining us. We'll see you in February. And thank you for all your hard work for moms, infants, and families in Kansas. Have a good day.